Hi, so my name is Jeffrey Schindler, and this is my virtual presentation over my senior capstone project, which included review of the different mechanisms behind migraine headaches, as well as dissections of the Pterygopalatine ganglion and the surrounding structures. So first off, what is the Pterygopalatine ganglion? The Pterygopalatine ganglion is a collection or cluster of parasympathetic nerve bodies located within the pterygopalatine fossa. The pterygopalatine fossa is a pyramidal space located basically deep and medial of the cheekbone, of the zygomatic bone. So the ganglion itself contains the nerve bodies of efferent parasympathetic nerves. So the branch of the autonomic nervous system thought as rest and digest. Your preganglionic fibers traveling from the brain or the brainstem will travel into the ganglion, synapse with the nerve bodies within the ganglion, and then send out the postganglionic branches to their effector organs. So the function of the pterygopalatine ganglion, as I mentioned, it's parasympathetic. And in the effector organs that are innervated by these nerves, which include the nasal mucosa, the palate of the mouth, the lacrimal glands, and meningeal vasculature, they will increase secretions, cause inflammation, and different effects like that. So in the nasal mucosa, activation of this ganglion is going to make you have a congested and runny nose. When you look at the lacrimal glands, it will increase lacrimation, so make your eyes water. And in meningeal vasculature, it will cause vasodilation and inflammation. So this inflammation is the reason for performing these blocks. It's what kind of led to blocking this area, made it a target for trying to treat different things. Because along with inflammation, you get decreased pain threshold, and as we'll discuss in the mechanisms, it's believed to be an integral part of a lot of migraine headaches and different things like that. So it was used as a tool for being able to limit that inflammation without going to the normal medications. Blocking the pterygopalatine ganglion is not only useful for treatment of migraine headaches, it's also used to try and limit postoperative pain and swelling after rhinoscopy or like endoscopic sinus surgery. It's been used as an alternative to blood patches to treat dural headaches that can occur after a loss of cerebrospinal fluid following an epidural procedure. It's even been used to try and treat back pain and to modulate cardiac autonomic tone and several other things. As the popularity of these blocks is kind of increasing in recent years, the different ways that it's being applied is also increasing. And it's interesting because things like cardiac autonomic tone, there aren't really any known pathways. There shouldn't be any direct connections between this ganglion and the heart, the cardiac tissue, that should lead to the changes that they see. Because it is new and very unknown, I did focus specifically on migraines, as that's been kind of the longest standing condition that these blocks are used for. Another note I forgot to mention on the last slide is that the pterygopalatine ganglion is also called the sphenopalatine ganglion. So that's why that is labeled that there, because evidently neuroanatomy by itself is not hard enough, so you also have to come up with multiple names for the same structures. So how are the blocks on this ganglion performed? One of the main advantages of blocking this ganglion itself is the fact that you can do it topically, so non-invasively, in a method that's called the transnasal topical approach. So in the transnasal topical approach, you can use a catheter or a cotton swab or any number of tools to gain access to the central sinus and follow the inferior portion of the middle turbinate until you have reached the posterior wall of the nasopharynx. Once you've reached the posterior wall of the nasopharynx, directly posterior to the posterior insertion of the middle turbinate, then you ideally should be directly over the ganglion itself, and you can apply the anesthetic like lidocaine or bupivacaine to the nasal mucosa. It then diffuses through the nasal mucosa and is taken up into the nerve bodies themselves. Other block methods have been utilized. Injections, so either inserting a bent needle into the central sinus, so a transnasal injection has been used. They can also gain access externally with what is called the infrazygomatic approach, where the needle is advanced from a posterior and inferior angle through the cheek and into the ganglion from the outside. The advantages of the blocks when you use an injection is that you typically get a more complete block of the ganglion. So if the patient was having kind of a more severe condition, sometimes they would do a formal injection. They're typically longer lasting. So with a topical application, most often you expect 4 to 8 hours for that block to be effective, whereas with injections it can be 12, 13, or sometimes even greater, depending on the concentration and the anesthetic used. So why perform dissections and do an entire study project on the pterygopalatine ganglion if we know where it's at, and you already have the diagrams and they're already using it clinically for treatments? And the reason is pictures like the one you see here make it look like it's this nice clear cluster of nerve bodies right below the nasal mucosa, and there it is. The reality is that the information that many of these diagrams and different things for books, and even the information used clinically, came from a single study in 1908 to 1909 by a physician named Sluter. He did several cadaver dissections and mapped the area, and since then that's basically been the information used. There weren't a lot of repeat studies done for a very long time to kind of see how accurate is this in different people. Obviously there's a lot of anatomical variation with everything, and this is kind of a very poorly studied area, so that's why I chose it for my capstone. So in my dissections, I conducted 5 dissections, and I was only able to locate the ganglion in 2 of them. I was never able to find the ganglion from the sinus cavity, as I thought I would be able to initially from the drawings. The distance between the ganglion and the central sinus, so if you can imagine, if you're doing the transnasal approach, this is the turbinate here that I'm outlining, you're going to land right in this region here. And according to the original study, the distance between the wall of the nasopharynx, the nasal mucosa there, the posterior aspect, and the ganglion, the distance should be about 1 millimeter. In my dissections, the 2 measurements I was able to get, so it would be about here to here, was between 6 and 8 millimeters. This wasn't a total surprise, as a recent imaging study that had been released, I believe it included 38 individuals. They found that the actual average distance was 6.77 millimeters, and the range was from 6 to 9 millimeters. So a lot farther than originally thought, and this is important specifically for the topical application because the hypothesized maximum distance of diffusion for lidocaine, for instance, is only thought to be about 1 millimeter. So if your distance is far greater than that, the chances that you're actually blocking that your numbing solution is getting into the ganglion itself is pretty low. The other thing that surprised me was that the ganglion itself was kind of spread out. It wasn't this nice discrete package. So here I highlighted this entire region yellow, and that's because it was kind of a mixture of several branch points of the maxillary artery that gives off like the posterior superior alveolar, posterior inferior, and more branches right there in the pterygopalatine fossa. And the ganglion was actually kind of wrapped around these branches, and then the axons leaving the postganglionics then follow a lot of that vasculature to their effector organs. This region here within the maxillary sinus that I highlighted is the infraorbital branch. So that is a branch of the maxillary nerve, and that is the maxillary nerve is actually what the pterygopalatine ganglion itself hangs from. So just rostral of the foramen ovale, or not ovale, rotundum. So just rostral of the foramen rotundum, the maxillary nerve exits the cranial vault, and then the ganglion hangs from it within the pterygopalatine fossa. And what I noticed was that the kind of relation between the ganglion and the sinuses wasn't primarily a relation to the central sinus. It was a relation much closer to the maxillary sinuses. So most of the bigger branches leaving the ganglion actually followed this infraorbital through the maxillary sinus. And the maxillary sinus is separated from the nasal cavity by the actual bone. So you have portions of the ethmoid and palatine and several bones. So everywhere here in black is where there is actually bone, creating a divide between the two areas. And the main communication is actually a very small hole right about in this region here, where the maxillary sinus communicates with the nasal cavity itself. So again, if there's actual bone in between where you're applying your block and the ganglion that you're trying to block, that again kind of suggests that perhaps we're not actually blocking this ganglion at all when performing a lot of these blocks. Here in the second picture, unfortunately, you can't actually see the ganglion here. This again is the infraorbital nerve and then artery, and here's a couple of the branch points that occur. The ganglion was located right in this region here. So again, you can't see it in this photo because it was actually behind this kind of bony ridge here. But again, if you're passing your catheter or swab or anything else, you're going to land right about there using the transnasal approach, and this is a pretty appreciable distance there, as well as separated by bone. So I only was able to complete 2 dissections, so obviously I didn't have a very large sample size, but in the 2 dissections I was able to locate it at all. The anatomy did not seem to mirror what I was expecting from the diagrams when I looked in my textbook or in a lot of the papers. It was very different. Originally the plan was to actually try and map the branches leaving the pterygopalatine ganglion to better understand its role in migraine pathogenesis and these different disorders that they're using it to treat. But due to the complexity of the region, as well as how much the tissues were kind of stuck together in the cadavers, I just was unable to do that. So that's where I transferred to try and get just a more general picture and idea of what the anatomy actually looks like. So now that we've discussed the anatomy of the region and what the ganglion is, the rest of this PowerPoint will be exploring the different mechanisms behind why we think that blocking this ganglion can help treat migraine headaches. So the first mechanism that we'll go over is the peripheral migraine mechanism. And this is kind of the long-standing, more general mechanism that you'll find when you search what causes migraines. So in the peripheral migraine mechanism, the initial event that is thought to lead to the migraine happens peripherally. And what would cause the first event, that trigger, is not known. It's wildly debated. But in the peripheral migraine mechanism, the first thing that occurs is firing of the sensory neurons. So these are first order trigeminal afferent neurons that innervate the meningeal vasculature. So, be it increased blood pressure or spontaneous vasodilation or what have you, something is thought to happen that triggers these first order sensory neurons, which are chemoreceptors and mechanoreceptors, to have an action potential. So as this action potential is traveling along the neuron back towards the brainstem, you'll have what is called orthodromic cell signaling. So that is the action potentials that are propagating in the direction that you expect them to travel. So where these are afferents from your innervated organ back to the brainstem or brain. Something that's interesting with the sensory C fibers of these trigeminal sensory neurons is that they will actually then trigger antidromic cell signaling. So this second arrow over here is an action potential going the opposite way that you would expect, back towards the original organ or tissue that is innervated. So as the action potentials continue on, you're actually triggering a reflex completely contained within just that first order neuron that, as it travels back down towards the meningeal blood vessel, it will then release substance P, CGRP, and several other neuromodulatory molecules. And these neuromodulatory molecules, the exact functions of them are not well known, but they have been shown to be involved in increasing an inflammation and depolarizing not only the sensory neuron that's releasing them, but also surrounding sensory neurons. So as these neuromodulatory molecules are being released, it's making it easier for more action potentials to occur within the sensory neuron, as well as causing mast cell degranulation and some cytokines to be released, which then increases inflammation in the surrounding tissues and also kind of spreads this cell signaling firing to other surrounding afferents as well. So as your orthodromic cell signaling travels along the first order neuron, it will eventually reach its synapse in the brainstem. And the first order neuron in this case synapses with the nucleus caudalis, which is a nuclei within the brainstem, and it contains second order neurons of the trigeminal sensory system. And these are nociceptive second order neurons. So they take the input from the first order sensory neurons, and they then transmit those signals to several different locations within the brain and the brainstem in the nociceptive pathways. So once this second order neuron or neurons have action potentials, they will then send action potentials in a couple different directions. One direction, as we're going up here, is to the thalamus. So I believe there are 5 thalamic nuclei that we know of that are connected to the nucleus caudalis. And these signals, these action potentials, will then synapse with the thalamic nuclei, and they will then trigger the thalamic nuclei to send signals up cortical pathways to the somatosensory cortex. So up in the somatosensory cortex, that's where you would become conscious that you're getting a headache. It would kind of be the first you're sensing it, it's become conscious. The second direction that these action potentials are sent is to the superior salvatory nucleus. And the superior salvatory nucleus is a parasympathetic nuclei that then sends off preganglionic fibers that will synapse within the pterygopalatine ganglion. So these action potentials that are being routed through the second order nociceptive pathways then stimulate the superior salvatory nucleus to begin sending action potentials and signals down the preganglionics towards the pterygopalatine ganglion. And as I talked about here, as all of this is ramping up, you have just now kind of reached your perceivable headache. And this is thought to be the reason that a lot of people feel migraines coming on. So as all of this is starting to occur, some of that signaling is making it up to the somatosensory cortex, and that would be likely when people are, they'll mention, I feel a migraine coming on, I know I'm going to get one. So as the preganglionics from the superior salivatory nucleus synapse in the pterygopalatine ganglion, so this is moving back towards the vasculature, it then triggers the nerves within the pterygopalatine ganglion to send action potentials to their effector organs. In this case, the effector organ is meningeal vasculature. So as that synapse reaches, or as the signaling reaches the synapse, then the parasympathetic will release acetylcholine, vasoactive intestinal polypeptide, pituitary adenylate cyclase activating peptide, neuropeptide Y, and nitric oxide, and probably others. But overall, the effect that is seen once you have activated these postganglionics leaving the pterygopalatine ganglion is that they will cause vasodilation, so they'll make the vessel become larger. They will increase vessel permeability, so you'll get increased protein extravasation occurring through the walls of the vessel, which you expect in an inflammation response. They will also then further induce the release of neuropeptide substance P, sorry. There's too many names to keep straight here. Substance P, CGRP from the first order neurons, as well as further depolarizing them, making them more sensitive to pain, and further excite that mast cell degranulation and activation of cyclooxygenase 2, which converts arachidonic acid into leukotrienes, again furthering the inflammation response. And then as that continues to keep exciting itself, so you're making more and more signals occur in the first order neurons, which further excites the second order neurons, which then further excite the superior salivatory nucleus, and on and on and on, then that is what is thought to be the runaway kind of self-exciting system behind migraines. So this relationship between inflammatory molecules, cytokines and then leukotrienes, like I mentioned, and mast cell degranulation is actually why in the cocktail that they will typically give patients when they come to the ER contains first generation antihistamines like Benadryl, so that's to help stop the signaling that's occurring from the mast cell degranulation, the histamines. They include ibuprofen or some other cyclooxygenase 2 inhibitor to stop the conversion of arachidonic acid into leukotrienes, and then they contain triptans, and triptans, though the mechanism is completely unknown, have been shown to reduce the levels of CGRP when someone is actively suffering from a migraine. So this mechanism is kind of what led to the combination of drugs that we will give people when they have migraines. So much like the peripheral migraine mechanism, the central migraine mechanism obviously contains all of the same pieces here. What's different is the initial cause of the migraine, or what is thought to be the cause. So you'll notice that we've added the para-aqueductal gray and nucleus raphe magnus into the schematic. The para-aqueductal gray and nucleus raphe magnus are nuclei within the brainstem. So the para-aqueductal gray is in the midbrain area, and then the nucleus raphe magnus, there's actually several nuclei starting in the midbrain, and then they kind of will descend down the brainstem. And they have lots of different functions, appetite control and different things, but they also play a key role in nociception. So what pain signals are being received and activated. So here we have the cortical inputs. So these receive several cortical inputs, and then they connect to each other, and then they will synapse with the second order neurons within the nucleus caudalis. So part of what supports this theory is the fact that oftentimes with migraines there will be visual disturbances that accompany the pain, the headache, like auras, blind spots, and there can even be visual disturbances as well. And things like visual and auditory disturbances suggest that there's a central trigger, because these peripheral structures would not be causing there to be dysfunction within the occipital lobe, for instance. And there's a phenomenon known as cortical spreading depression, where there's this depolarizing wave that travels through the cortical pathways and has been linked to auras and auditory disturbances and different things like that. So the theory is that perhaps as this cortical spreading depression propagates throughout the different nerve bodies, it then results in dysfunction of the para-aqueductal gray and nucleus raphe magnus. So when everything's working properly, just the beating of the heart, the natural rise and drop in blood pressure, is likely sending signals down these first order neurons. The difference is that the second order neurons do not send action potentials. So this first action potential reaches its synapse, but due to the nucleus raphe magnus and para-aqueductal gray, which are thought to hyperpolarize these second order neurons, the second order neurons do not send any cell signals. So it's basically being ignored. Your body's going, okay, this is normal, and doesn't do anything. However, if there's cortical spreading depression or any other number of possible causes for dysfunction within these nuclei, as this dysfunction spreads, now when our first order signal reaches the synapse, it does cause action potentials to be sent out from the second order neurons within the nucleus caudalis. And now in the same exact way, the signals propagate up the thalamic pathways to the cortical pathways, to causing a perceivable headache. At the same time, it also is exciting and stimulating the superior salivatory nucleus, which then transmits to the pterygopalatine ganglion, and then you get the release of those nitric oxide and acetylcholine and different things at the junction there, which then causes an inflammatory response and a migraine occurs. So the runaway kind of system of that inflammation and the cell signaling in the loop is the same between the peripheral and the central migraine mechanism. The key difference is the question of, does the initial event occur peripherally in the vasculature itself, or is it dysfunction centrally that then allows normal cell signaling from those peripheral structures to kick off and start this kind of whole vicious circle going? And because of that, these aren't exclusive theories of each other, because sometimes you see the inflammation with migraines, sometimes you don't. Sometimes there are auras that accompany migraines, sometimes there aren't. So it's likely just a combination of all of these things and many more. Now that we've gone over the different mechanisms behind the migraine headaches and what is thought to be occurring, that self-exciting cycle of more cell signaling leading to more pro-inflammatory messenger molecules being released, and then more inflammation, and round. This final piece here is just showing where the pterygopalatine ganglion block fits in the treatment of migraines. So by blocking the parasympathetic postganglionic fibers that are leaving the pterygopalatine ganglion and traveling to the meningeal vasculature, you're able to stop the release or limit the release of the nitric oxide, acetylcholine, VIP, and different things. And once you can stop that, then that will help the blood vessel return to normal size, which will help stop the action potentials traveling down the sensory neurons, and you get less neuromodulatory molecules being released there, less mast cell degranulation, and so on, to kind of let the entire system calm down and return to baseline. So by removing that one link in the circuit, you're able to let the rest of it stop kind of playing off itself. And this is why the blocks are thought to work for treating the migraine. So when someone comes in and they have a migraine and they receive a block, oftentimes that will alleviate the migraine headache for much longer than the 4 to 8 hours that the block itself is active. And that's why this is thought to occur, because you're just basically removing a piece, letting the body return to normal, and then you no longer need that block there to stop the migraine once everything else has calmed down. So in summary, neuroanatomy is hard. This was a very challenging but rewarding research project. Constantly got to learn how even when I thought I had it down at all, I was wrong again. But it was an incredible opportunity to kind of better learn how we think things are working with migraines. And I got to learn a lot about the nerves and orthodromic and antidromic cell signaling and so on. And the pathogenesis of migraines is, again, very debated. So neither of those mechanisms are a complete catch-all. There's still a lot of unknowns and kind of factors that we don't fully understand. So, and then with the review that I conducted and the dissections that I conducted, and the growing evidence that we're maybe not even blocking the ganglion itself, but maybe just blocking the nerve fibers that are traveling below the nasal mucosa where they're applying a lot of those blocks. I think that the reason that it's likely still working is because this is just such a large, complex system. So you may not need to actually numb and block the entire ganglion itself, but maybe just stop some of this excitatory cell signaling is going around and around. And then finally, I think that how different the anatomy was. It was so different from the diagrams and the drawings. And because it was so different from what you will typically find when you look up the anatomy of the region, I think that my findings definitely warrant kind of further research into this. As this procedure's gaining popularity and being used more, and especially when talking about injections into the ganglion itself, is really important to know the area and know the landmarks and the normal relations to help limit the chances of, with injections, possibly damaging surrounding structures or missing the ganglion entirely. So hopefully there will be more research put out on this and I can kind of continue to follow it. I just wanted to take a moment to acknowledge Bryan College of Health Sciences. Obviously, I wouldn't have had the opportunity to do any of this without the resources that were given to me by the college. And then Dr. Mark Jones, who let me burst into his office countless times and share my frustration when I couldn't find it, and ask why the papers didn't match what I thought I knew, and so on. So he was just a huge, huge help in helping me learn enough to be able to get this research project together. And then Dr. Kim Hansen, so she helped me get the ball rolling and get my research started. And oftentimes that, is definitely the hardest part because it's really overwhelming at first. So just wanted to make sure to give a moment to thank everybody here. And finally, there are my references.